Let's be direct about what's happening here, because the implications are far larger than most people realize. The idea that artificial intelligence will conduct the first layer of mental health assessment before a human clinician ever enters the room is not science fiction. It is a clinical trajectory already in motion, and it demands scrutiny rather than celebration. The current psychiatric system has a foundational problem that rarely gets acknowledged plainly. Initial diagnosis is almost entirely dependent on what a patient chooses to say, remembers to say, or is capable of saying. Self-reporting is the backbone of psychiatric assessment, and it is genuinely unreliable. People minimize symptoms out of shame. They dramatize them out of desperation. They forget. They lie, not always maliciously, but because describing one's own psychological interior is one of the hardest cognitive tasks a human can perform. This is where AI enters with a technically compelling offer. Pilot programs using natural language processing to analyze voice patterns have already demonstrated accuracy rates exceeding 80% in detecting depression. These systems are reading prosodic features, pace, flatness, micropauses that most clinicians never formally measure. Facial microexpression analysis adds another layer, identifying emotional leakage that patients aren't consciously aware of broadcasting. When you combine voice, expression, and behavioral data, you begin constructing a diagnostic picture with a kind of objectivity that human intuition simply cannot match at scale. That is a genuine advancement, and it would be intellectually dishonest to dismiss it. But here is where the analysis must become uncomfortable. The moment we begin generating data that can identify someone as a depression risk, a psychosis risk, or a suicide risk, and that data exists in a system connected to any external network, we have created something potentially catastrophic for civil liberties. The question of who owns mental health data is not a footnote. It is the entire ethical architecture that has to be built before this technology is deployed at population scale. What happens when an employer's insurance carrier receives an algorithmic flag that an employee is a suicide risk? What happens to someone's mortgage application when underwriters gain access to AI-generated psychiatric profiles? These are not hypothetical scenarios. They are the predictable commercial destinations of unregulated health data. There is also a subtler clinical risk that doesn't get discussed enough. AI diagnosis, however accurate on average, will produce false positives, and a false positive in mental health isn't like a false positive on a cholesterol screen. Being told you are at elevated risk for psychosis can itself be psychologically destabilizing. The communication of AI-generated risk scores to patients requires protocols that do not yet exist. None of this means the technology should be stopped. Redirecting psychiatrists away from screening and toward treatment, where their expertise is most irreplaceable, is genuinely valuable. But deployment without robust legal frameworks around data ownership, without patient consent architecture that is more than a checkbox, and without clinical communication standards, would be a serious mistake. The science is ready. The infrastructure around the science is not.